speaker for our first segment of the image acquisition, analysis, and interpretation section of the symposium will be Dr. Robert Hamilton of Neurosignal. Dr. Robert Hamilton is the CEO and co-founder of Neurosignal, leading efforts to integrate AI and robotics into transcranial Doppler for advanced cerebrovascular monitoring. Thank you so much for joining.
Thank you. Let me switch these around. I apologize. Switching screens. Let's do. This keeps on dropping down. Apologize. There we go. Switch. How's that?
Perfect.
Perfect. Well, thank you again for the organizers and the talks this morning, afternoon, or evening, depending on where you're at. As they mentioned, my disclosures, I am the founder and CEO of Neurosignal, as well as my active funding. We're taking a little bit of a different approach, excuse me, for this talk today. I wanted to take a step back and look generally at how we approach advancing transcranial Doppler as a modality, both technically and clinically. So although I am the founder and we have a commercial system, I'll be talking more generally about applications and approaches. So the last two speakers did an excellent job of talking about the limitations of transcranial Doppler and approaches. So I think that my talk will complement theirs well, as we are trying to address the same limitation through different mechanisms. So if you think about the role of artificial intelligence and robotics, the real goal here is first and foremost to improve the quality of acquisition, garbage in, garbage out, if you're thinking about from a data analysis perspective, using artificial intelligence to expand the clinical value. How do we expand it outside of the neurocritical care unit today for subarachnoid hemorrhage and into different indications, impacting as many patients as we can, and then ultimately increasing access of the technology outside of strong academic centers into community-based hospitals and eventually any healthcare professional. So if we start to think about where artificial intelligence and specifically robotics can come in, I like to break this down into two different broad areas, which is in as you saw in the last few talks, how do we improve the acquisition? How do we allow that to be user independent, or at least reduce the barrier, or in some cases, just reduce the burden on the expert technologists that have spent years doing this to allow them to continue to expand their importance within the hospital and clinical care settings. The next piece, after we've acquired that data, is to how do we start to analyze it at a deeper level? And obviously, artificial intelligence is everywhere today, but both of these elements are needed in order to really impact clinical value and provide data to our clinical partners that allows them to make critical life-saving decisions. So first, I'll start with data acquisition. The way we like to think about this is in much like a spectrum, and you saw this in the last few talks, excuse me, in the last few talks, and different approaches on how to solve this. And I don't believe there's any silver bullet. All of these are trying to get to the same idea, which is going from a completely manual state and expanding that through either AI assist technologies, which I'll be going over, robotic assistance, all the way through complete automation. And it is important to know here that this really isn't about replacing individuals. This is about allowing technology to support them in the ultimate collection of this data to improve the overall quality of the healthcare system and allow people to do their jobs as efficiently and easily as possible. So we'll be talking about different applications throughout this spectrum today. So the first is technologies that are used today, and more will be coming out. So the first is in AI assist technologies that allow feedback to the user in real time that support the collection of this data in a more accurate, easier way. So when I was first trained in transcranial Doppler, as many of you know, it could take an hour, maybe even longer to do a complete study in the ICU. And so there's a number of different technologies that we and others have rolled out to help support that individual when they're making those decisions. And I know that several talks over the course of today will also hit on these points, which is fantastic to see all the innovation. The first is in signal quality assessment. How do you start to look and actually quantitatively score signal quality? This is a very well understood dynamic within engineering, applying that specifically to transcranial Doppler. Vessel identification, especially for blind Doppler, needs support as well from an angle of insonation or depth perspective. And then ultimately, and the world has really changed over the last couple of years, looking at report generation and possible applications of LLMs and known databases within taking all that information and easing the burden on both of those individuals writing the report, but those also interpreting the report. Ultimately, having a clinician be the gatekeeper there, but have as much support as we can for those individuals. The next is in robotic assist and full automation technologies. So I like to break this problem down into window identification. How do you solve the identification? What you see up here in the upper right hand portion of the screen is the tragus of the ear and then the eye. These are all different locations mechanically insonated. And so this is a different approach than Dr. Shu talked about very eloquently earlier in acquiring and finding that window first. And then the next part for anyone that's done transcranial Doppler is actually optimizing that signal. How do you reduce the angle of insonation to improve the quality of that data? And so all of these are unique, and both these are the real two problem sets that you're trying to solve when doing transcranial Doppler. Again, you can broadly break the problem down into mechanical insonation or electrical beam steering. There are a number of applications, commercial applications that have been in use. They each have different kind of approaches to this. I won't go into all of them. I'm sure most of the people are either aware or have used various forms of these automated and fully automated technologies. The data is good so far that has been published. It aligns well both on the normal patients as well as the pathological patients, and specifically adds an element for somebody to long-term monitor these patients. I think Dr. Shu mentioned very well as I was a student at UCLA. Holding that probe or monitoring that probe for several hours is very difficult to do. So allowing technologies to not only identify but continuously monitor for not only tens of minutes but hours will hopefully change the field and how we use transcranial Doppler today. So if we think about AI guidance, this has been done, and I think some of the previous talks and talks coming down the pipe here will talk even more about this. With advanced technologies, this has been applied in other areas of the body. Several of these companies have been acquired by the larger ultrasound companies, but allow AI guidance to help support where you're looking and how to acquire this data. So I'm excited about not only the talks that have been given, but some that will be coming today. And then really the future of this, I think that this is something that we've seen again today, and things that we've demonstrated as a group as well, that now that you have a point spectrum, you can actually combine that information because specifically in our case, when you have a 5 degree of freedom robot, you're able to stitch together that information and provide a much more complete view of the cerebral vasculature, unlocking opportunities for those the clinical partners that are making these life-saving decisions. So next, now if we move past the idea of the acquisition of the data, what can we do with it? And this is something that really my research early on focused on before founding Neurosignal, which were just taking a broad step at steps of machine learning. So the first step in what we've talked about today is so far about getting the data. I mentioned garbage in, garbage out. We want to get the most robust data set that we can before ultimately developing a training model and test model. And how do we extract those features from it? So those of you who are familiar with transcranial Doppler, you'll also know that there's a tremendous amount of data behind the spectrum with the IQ pairs that is also an opportunity to extract valuable information from. But traditionally, transcranial Doppler leverages a few different elements that we want to extract features from. The first is the spectrum and the velocity envelope. Then there's a power M mode signal. And then if you have robotic positioning, you also have positioning within the intracranial vault. And that's an important element as well for vessel identification and ultimately vessel mapping, which we've been able to demonstrate quite well. So I just wanted to give a few examples from a high level of today, for the most part, clinical assessments of transcranial Doppler rely on mean velocity, peak systolic, end diastolic, and PI. From a data science perspective, this is leaving a lot of data on the table. And so looking at that point by point morphological data is incredibly important. I will say I did take this slide from Dr. Rubin. This shows an example of two completely different waveforms, but the same mean velocity and PIs, or systolic and diastolic, I'm sorry. And so we've also seen this for vasomotor reactivity studies. So how do we start to capture this? And this is something that has been in the academic literature for several years, looking at different quantitative ways to capture morphological analysis of the subpeaks, led by several groups. And as I think Dr. Shu mentioned before, really standing on the shoulders of giants here, looking at the different assessments. So a number of publications you can see here have tried to quantify. I think as a field, we need to come together and realize that these metrics do provide value and we should standardize how we talk about them. That is really the first step in the ability to get these into clinical practice, whether that's systolic slope, which is traditionally used in other forms of vascular imaging, P1 and P2 ratios, curvature, and even latency ideas as well. So I do have a request for the group. Happy to participate as I can, but to really come around a common lexicon for these to be able to move forward. So this is important because as you start to pull out, and I'm a firm believer in this, physiological mechanisms. If you start to think about black box applications for machine learning, they're obviously out there. But if we can pull physiologically relevant and identifiable information out, the explainability of those features and tying those into physiology is just going to make it that much faster and easier to adopt. So this is one of those things that, again, I think as a field, we need to come together on and come to a common ability to identify and measure these metrics. So finally, I'll just talk about some of the examples from our group and some of the recent data that we have. So again, looking at the machine learning, now we've talked about getting the data, acquiring the data, cleaning the data, and extracting this. The first quick example is non-invasive ICP. We just finished a DoD study. That data should be out in the next several months. But this really, again, looked at the morphological information. So you combine the data analysis with the automated robotics. And you're able to show that there's a dramatic increase in the overall accuracy for intracranial hypertension detection. So if you look at traditional analysis, looking at pulsatility index in these, this is around 100 patients in the ICU. And then you looked at the morphological information, you were able to increase through a machine learning method the ability to look at intracranial hypertension by dramatically increasing that AUC. This study was more recent, looking at large vessel occlusion detection. This was done in around 150 patients within the ER, looking at M1 and M2 occlusions. So again, instead of taking a black box approach, we looked at specific morphological analysis, which was just the overall curvature of the waveform. Looked at that and some asymmetry ratios between the left and right sides. And you're able to say from an ICA M1 and M2 group in the ER, we were able to increase sensitivity and specificity to 94 and 88% respectively. And so again, this is just capturing the morphological information, this incredibly valuable data that's within the data set. So, in conclusion, as therapies continue to advance and telemedicine becomes more and more of a reality, the importance of TCD, I believe, will continue to expand. And I think it's our job as not only technologists but clinicians on the call today to continue to expand the importance of neurovascular care. I think you can broadly say AI, robotics, or automation, as some of the talks today have shown that you don't need robotics to do this. You can do it electronically. But there are advantages from a robotics perspective as well. We should embrace these tools as a field and continue to see how they can improve data access and data analysis. And then obviously deep learning and these modalities, cautiously, we should look at those and see how we integrate those within our day-to-day analysis. So with that, I will end. Appreciate the attention and happy to address any questions.